So welcome. Today we'll be talking about the basic views when we are doing point of care ultrasound in emergency medicine. So what are we going to talk today? Well, mainly what views do we use, where do we position our probe, and what's the normal sonoanatomy. So when I put the probe there, what do I want to see in a normal healthy person? We're going to walk through some protocols, mainly the mostly well-known, the EFAST, the bedside lung ultrasound exam, so the blue, the CASA, that's the ASAP protocol for cardiac arrest, RUSH for shock, and we are going to take a look on the carotid and the jug. So the EFAST is the most well-known ultrasound protocol for trauma. We have these views. Some people call this the EFAST because we are doing the lung ultrasound. So we are looking for signs of pneumothorax, also for free fluid in the belly and signs of cardiac tamponade. The blue helps us identifying a lot of lung pathologies, pneumonia, pneumothorax, and several other cases that we can use. We usually use these 3 main points in each side, so at least 3 points on each lung, so upper, lower, and the flaps. The CASA exam, so it's every time we stop to check the pulse of the patient, we are trying to see something in this exam. So we are taking a look in the heart and trying to find a cause or some sign of something that I can do to make this patient better. And the RUSH protocol is the one with most views. It's a very thorough protocol. So we are checking the lungs, the belly, the IVC, the aorta. We are looking for pumps, pipes, and trying to see what is causing the shock of our patient. So this is a very we see a lot of views in this protocol, and this is mainly what we are discussing, because if you see the CASA, the RUSH, and the blue, they are all within the RUSH protocol. So this is mostly what we are going to discuss now. Also very important for us is to take a look on the neck, especially the carotid artery and the jugular vein. Mainly because when we're thinking about a central access, so that we have seen that there are several studies that to do this kind of procedure using the ultrasound makes much safer, much easier, and has less complications. And also something that's growing a lot is that instead of doing our manual pulse check when we have a cardiac arrest, we use the Doppler to see if our carotid is pumping. So it's another new use for the neck ultrasound. So when we are seeing the neck, we have mainly 2 views. So this view, we are seeing a transversal cut of the carotid. We can see it's very round, pulsatile, and the jug is more oval shaped, not pulsatile, and when I press lightly with my probe, I can see it shrinking. So this is one of the things we look for in veins. And if I use the Doppler, red doesn't mean this is an artery. It just means that the flow is coming towards our probe, and blue is going away from the probe. So I have the probe a little bit inclined to the head, so I can see this pulse in red, meaning I have flow coming to my probe, and this more linear blue flow, that's the jug. So we can differentiate both flows in this with the Doppler. And if I have this other view, I can see the vein and the artery in another cut, in a more longitudinal cut, and it helps especially when we are thinking about getting a vein. So if I'm trying to get a catheter in, we will use both views, both to have some landmarks, to make sure that I don't have some anatomic variation and that I have my needle inside the vein. So this helps a lot when we are thinking about this kind of procedure. Going down, now we reach the thorax. What we are trying to do here is get our probe between two ribs, and this is the view we want. What are we seeing here? We see the rib shadow of both ribs. We see this thicker white line, that's the pleura. It's sliding, so this is a good sign. This is what we are looking for. And we can see the subcutaneous, and the probe is of course in the skin. And I can't really see the lung because air is not a very good conductor for sound. So I can see this movement, some lines, some artifacts, but I can't really see the lung itself. So we see these things, these artifacts below the pleura. If we're now going to the heart, this is the one that has most views. We are trying to get 4 views from the heart to have a more thorough view of what we are, something that may be wrong. So the first one is the parasternal long axis. So I have my probe. We usually start between the 3rd and the 5th ICS, and we are scanning until we see something moving. When we see something moving, we stop and try to get the view we want. Sometimes we have to go down to the 7th ICS, so this is varies a lot from patient to patient, but we are scanning parasternally. We have the probe usually 90 degrees, and when I find something moving, I will get the marker, so the little dot on the tip of my probe, to my right shoulder. So I have my heart like this. When I'm pointing the probe to the right shoulder, I'm cutting the long axis. So this is the view I'm trying to get now. And we can see this view. So closer to our chest wall, we have the right ventricle, the left ventricle just beneath it. And we can see the left atrium in contact with the aorta, and we can see both mitral and aortic valve. So this is a very good view for us to see how the left ventricle is contracting and if we have any valval problem. So this is a very good view. Also, we can have some idea of the right ventricle. And to get the short axis, so the short view, I have my heart here. I was pointing my tip to the right shoulder. Now I just point my tip to the left shoulder. So now I'm cutting the heart like this. And I'll see this. This is more transversal view of my ventricles. Always the right ventricle is closer to the chest wall. And I will just swipe down and up to see other views. I can see very well the mitral valve, the papillary muscles. So this is also a good view to see how my left ventricle is contracting, and that is a good view to see if my right ventricle is bigger than my left. So this is a very good view too. And also this view will help us getting our next view. That's the apical 4-chamber view. So I have my probe here. I just found my short axis, and I will go with a Z motion or just following, trying to get this axis until I cannot no longer see the chambers of the heart, just the little tip of the muscle. That's the ictus. Usually is around the mid-clavicular line, just on the 5th of or 7th ICS, just under the nipple. So but the easiest way to get is like I get my short view and just go until I can see the ictus. And if I find the ictus, I already have this axis because I know where my parasternal view is, and I just turn a little bit my probe so I can cut and get the view I want. So I'm trying to get the 4 chambers. That's why the name is Apical 4 chambers. And I can see this. This has a caveat that I don't have other anatomical markings. So if my marker is not pointed to my left arm, if it's pointing to my right arm, I will have a wrong view. I will think that my right ventricle is bigger than my left ventricle, and this is not good because I don't have any anatomical marker here to say that this is left, this is right. So I have to trust my probe marker. So this is very important that I'm pointing to the right side, or in this case to the left side. After that, we are going to check the Suboxified view. So again, the marker to the left arm, I'm coming the epigastric region, midline, a little bit to the right, and I'm swiping until I can see my heart, usually pointing for my left shoulder. And I'm trying to get this view. I have the liver, so this is a very good marking because I know that my right heart is in contact with the liver, so I will not misjudge it. And I can see the 4 chambers. So this is the view I'm trying to get here. In around the same position, we are going to check the IVC, so the inferior vena cava. But instead of being pointing to my left shoulder, I will be a little bit more on a 45 degree with the skin. And I'm going to go for lateral swipe until I can reach where the cava is entering the atrium. So the view I'm trying to get is this one. So I can see the IVC and the right atrium, and this is where we are going to evaluate it. So this is the view I'm trying to get. Also, as we are checking the pipes, I'm going to check the abdominal aorta. So in the same place, epigastric, midline, I'm going to try to find the aorta that's pulsatile, and I'm going to swipe my probe downwards. And I'm going to see if I can see the size, if I can see anything wrong with the aorta, till I reach more or less the belly button. That's when the aorta is dividing in the iliacs. So this is the view we can see here. That's until the place we are going. And now the views that are on Russia, and especially these are very well known because of the fast, we have the hepatorenal, or the right upper quadrant, and this is the view we are trying to get. So the lung, the diaphragm, the liver, and the kidney, and I'm trying to get them all in the same picture. We have to remember that the liver is very backwards, so it's one of the most common mistakes trying to find here more in the front. You're not going to get it. You have to really swipe down until you can get this view. So, and we have the splenorenal, or the left upper quadrant. The view is pretty much the same, but instead of having the liver, I have the spleen. But the way the structures are presented is pretty much the same. So this is the image we're trying to get. Also, we have the suprapubic. I have to go really down. Sometimes you have to get the pants a little bit down because I'm trying to get the right over the pubis. So I'm trying to get this view. The bladder, this is a rather full bladder, so I can have this very good view. And this is a male image because I can see the prostate just beneath the bladder. This can confuse a little bit because you may think it's free fluid, but in males we have to remember the prostate is behind. So we check the bladder, check to the sides, and see that there is no free fluid. That's what we are trying to get here. And those are the most common views that we are going to try to see on a POCUS exam for a very critically ill patient on the bedside. So this is the main views we get. So if you have any questions and any doubts, just drop the comments below, and see you next time.